So, hi, everybody. Welcome to the Hennepin-University Partnership webinar series. Today's webinar is titled Beyond Opioids, Tracking the Evolving U.S. Overdose Crisis Since COVID-19, and is presented by Senior Research Fellow Colin. My name is Margaret Stumbo-Turvey, and I am a Senior Project Manager with the Hennepin-University Partnership. We're also joined by Hub Director Amy Delahanty. The Hennepin-University Partnership is a collaboration between Minnesota's most populous county and its only land-grant university. At HUP, we're dedicated to catalyzing and supporting mutually beneficial relationships. The partnership has led to nearly 500 joint projects, combining academic research and local expertise to inform policy and practice for the benefit of Hennepin County residents. The goals of this webinar series are to offer information exchange and showcase research. While this webinar is designed primarily with a Hennepin County audience in mind, it is also open to the public and our university partners. We know people are joining today with different levels of familiarity with the topic. Our presenter will aim to address the subject matter from a range of perspectives, and we hope the session is both accessible and informative for everyone. Before we get started, just a few Zoom reminders for our audience. Your video, audio, and chat are not enabled. If you need any support from the HUP team, please use the Q&A function. If you'd like to ask a question, you can submit that through the Q&A function at any time throughout the presentation. We will monitor questions throughout and save time to address them at the end. As I mentioned, this webinar is being recorded. Please look for an email tomorrow with a survey and a link to the recorded webinar video. And finally, we're so happy to welcome and introduce the presenter. Colin, MPA, is a staff researcher at the Cannabis Research Center and the State Health Access Data Assistance Center. He has more than 15 years in health policy research and communications, including a decade at the University of Minnesota School of Public Health. In his work, Colin focuses on helping policymakers and public officials at varying levels of government to use data and research evidence to influence policies that equitably enhance public health. Now I'll turn it over to Colin for the presentation.
All right, thank you very much, Margaret. Let me pull up my slides real quick. Okay, so my name's Colin Planalp, and I'm a staff researcher at the University of Minnesota School of Public Health, where I've worked for the past 11 years. Work in positions at the State Health Access Data Assistance Center, known as SHADAC, where we conduct research and provide technical assistance to policymakers on the use of data, research methods, and research evidence to inform health policymaking, as well as the Cannabis Research Center, which was established in 2023 when the Minnesota legislature legalized cannabis for non-medical use by adults. I also want to explain a bit about my background and how I approach my work. First, before I made a career transition to public health, I worked in journalism and health communications. That mindset influences all of the work that I do these days, as I put a strong emphasis on producing data and research evidence that's accessible to non-technical audiences, especially policymakers and those who influence policymakers, such as voters and community members who petition and elect their policymakers, as well as the news media who play a key role in informing the public and shaping the policy agenda. Second, I want to come back to the point that I'm a staff researcher, not a member of the academic faculty at the University of Minnesota. That's germane for you all because it explains why I'm so focused on applied rather than academic research. My currency is helping health policymakers and practitioners serve the public and the public interest, not necessarily to publish papers for peer-reviewed journals. If writing up results can help achieve those goals, I'm open to the idea, but it's not my first inclination. But even then, I generally lean towards self-published reports and briefs, putting them out in the public domain for anyone to use rather than publishing in journals with paywalls. So on to my presentation. Since I suspect that everyone on this webinar knows a little bit, and in some cases a lot bit, about the opioid crisis, I'm not going to belabor the history, but I do want to provide a bit of background to explain where I start my analysis. It's generally accepted these days that the opioid crisis has its inception in the 1990s, with the confluence of factors, including the enhanced focus on healthcare, on the treatment of pain, and the marketing of blockbuster opioid painkillers such as OxyContin. Eventually, the scale and worsening trajectory came to the attention of national public health officials, with the U.S. Centers for Disease Control and Prevention declaring deaths from prescription or opioid painkillers as an epidemic in 2011. That year marked an inflection point in the opioid crisis, which I'll come back to as I present data on drug overdose deaths. I'll touch really briefly on the data and methods for this analysis. This research uses mortality data released for public use by the National Vital Statistics System. These are based on death records that are reported by the states to the CDC, which then harmonizes the data. For the most part, the data I'm presenting today are rates of death per 100,000 people. That allows us to conduct comparisons across groups and geographies and over time. Generally, I use age-adjusted estimates. We can talk about that decision if folks have questions about that later, except in cases where that isn't possible. The data also includes standard errors, which we use to conduct t-tests to assess for statistical significance. For ease of presentation, I simplify how we describe some of the drug categories. For instance, what I call fentanyl overdose deaths actually represents a broader group of synthetic opioids other than methadone. But I don't do this arbitrarily. This is based on CDC research showing that these shorthand drugs that I'm talking about are the predominant substances involved in fatal overdoses from each of these drug categories. I'm going to start by showing some trends in the opioid crisis from the past decade. Since the CDC declared an epidemic in 2011, fatal overdoses from prescription opioids have remained largely steady, varying a bit over the years, but not by much compared to other substances. The most recent finalized national data we have are from 2023, and we see that from 2011 to 2023, death rates from prescription opioids have dropped 23%. But during that same time period, overdose deaths from fentanyl have skyrocketed, growing roughly 30 times from 2011 to 2023. They're now almost 8 times the rate of prescription opioid deaths. During that same time, cocaine overdose death rates increased 6 times. Cocaine overdose deaths are now almost triple the rate of prescription opioid deaths. And death rates from psychostimulants, predominantly methamphetamine, increased 14 times during this time period. They are now almost quadruple the rate for prescription opioids. When you look at all 4 drug categories together, you can see that fentanyl really eclipsed prescription opioids as the main drug cause of overdose deaths. However, cocaine and methamphetamine have also tracked a really concerning trend, and one that's likely to pose unique challenges into the future. Now let's move on to the opioid crisis since the beginning of the pandemic. Here we can see fatal drug overdose death rates for fentanyl, methamphetamine, cocaine, and prescription opioids for 2019 and 2023. Each of them changed significantly, with the first 3 increasing and the last, prescription opioids, declining slightly. From 2019 to 2023, fentanyl overdose death rates nearly doubled, as did cocaine overdose death rates. Methamphetamine overdose death rates more than doubled, while death rates from prescription opioids declined 18%. But it's also important to recognize that these drug categories are not mutually exclusive. Instead, they're closely intertwined. Here we see a couple of things. First, the pie chart shows that 69% of fatal overdoses from prescription opioids also involve fentanyl in 2023. Second, the table shows 2023 rates of prescription opioid overdose deaths with and without fentanyl. On the right column, we see that the rate of fatal prescription opioid overdoses without fentanyl involvement was only 0.9 deaths per 100,000 people. This slide on methamphetamine also shows a couple of important data points. First, 69% of methamphetamine overdose deaths also involve fentanyl. Second, the rate of fatal methamphetamine overdoses alone, without any fentanyl involvement, was 3.4 deaths per 100,000 people. That's very nearly the rate of fatal prescription opioid overdoses in 2011, when the CDC declared those an epidemic. This tells me that the US has a methamphetamine epidemic just as much as it has an opioid epidemic. And finally, cocaine. We see that 80% of cocaine overdose deaths in 2023 also involve fentanyl. And the rate of fatal cocaine overdose deaths without fentanyl was only 1.6 deaths per 100,000 people. That's essentially unchanged from historical rates. Fentanyl is obviously the driving factor in the trend of rising cocaine overdose deaths. I also want to talk about the landscape across the states. That's partly because my work focuses primarily on state health policy, but also because it helps to illustrate how widespread the opioid crisis is geographically, as well as how it varies regionally. Starting with fentanyl, we found significant increases in fatal overdoses in states between 2019 and 2023. That occurred in 43 states. At the state level, we see wide variation, from a low of 3.3 deaths per 100,000 people in Nebraska to a high of 69.2 deaths per 100,000 people in West Virginia. To put that astronomical West Virginia number into perspective, if that rate were the US rate, it would make fentanyl overdose deaths the third leading cause of death after only heart disease and cancer. That's a fact that I find really astounding. Minnesota's rate at this time was 17.0 deaths per 100,000 people. This map shows whether a state's fentanyl overdose death rates are significantly higher than the US rate in orange, significantly lower in dark green, or not significantly different from the US rate in light green. For fentanyl, we see death rates tend to be higher in the eastern US. The rate in Minnesota is significantly lower than the US rate for fentanyl. Moving on to methamphetamine, we see that rates increased significantly in 44 states from 2019 to 2023. No state saw significant declines. Again, we see quite a large spread across the states. And again, we see West Virginia with the highest rate at 46.2 deaths per 100,000 people. Here, Minnesota's rate was 9.9 deaths per 100,000 people. The map for methamphetamine is different from fentanyl. Methamphetamine has historically been a problem in the Midwest and Western US. But we now also see it as a growing issue in states at the epicenter of the opioid crisis a decade or more ago, such as Ohio, Kentucky, and West Virginia. I also want to mention that this map looks quite different than it did before the pandemic. Before the pandemic, you saw much more red in the Western US. The rate in Minnesota is not significantly distinguishable from the average US rate in this case. Increases in fatal cocaine overdose death rates were also widespread across the states, though slightly less so. There were 42 states with significant increases from 2019 to 2023. Here we see another widespread in rates across the states. Though we see that the District of Columbia had the highest cocaine overdose death rate at 31.9 deaths per 100,000 people. That's not particularly surprising because cocaine overdose deaths tend to be higher in urban communities, and the District of Columbia is exclusively urban. Minnesota's rate for cocaine overdose deaths was 4.2 deaths per 100,000 people. This map is interesting because of how tightly clustered the states with high cocaine overdose death rates are, all east of the Mississippi. And that's a pattern that's been consistent as long as I've tracked these data over the years, roughly a decade. Minnesota's rate is significantly lower than the US rate for cocaine overdose deaths. Moving on to prescription opioids, we see a very different picture. For one, there was only a single state that experienced a statistically significant increase in prescription opioid deaths from 2019 to 2023. The rest of the states saw their rates hold steady or even decline. We also see a much smaller spread across the states in terms of the size of their rates, ranging from a low of 1.3 deaths per 100,000 people in Hawaii and Nebraska to a high of 7.6 deaths per 100,000 people in West Virginia. In this case, Minnesota's rate was 1.8 deaths per 100,000 people. This map is also distinctly different from cocaine, which had the higher death rates tightly clustered in the east. Here, they're relatively evenly distributed across the US. And here again, we see Minnesota with a rate that's significantly lower than the US rate. Next, we'll look at US level data by demographic subpopulations. This chart shows death rates by drug type and by age for opioids. What I find interesting here is that across drug types, fatal overdoses tend to be highest among adults in prime working age, from 25 to 54 years old. Adolescents and young adults experimenting with drugs aren't driving death rates. That said, adolescents experience some of the largest increases in drug overdose deaths since the pandemic began, with fatal fentanyl overdoses among adolescents aged 13 to 17 roughly quadrupling between 2019 and 2023. That was the largest increase we saw among demographic subgroups for fentanyl overdose deaths. That's a big change, and it's concerning because for adolescents, drug overdose death rates have remained relatively low and relatively stable for most of the opioid crisis until the pandemic began. Another surprising development were the increases in drug overdose death rates among elderly adults. For instance, fatal fentanyl overdoses more than tripled among those age 65 and older during this time period. For methamphetamine death rates, the pattern looks roughly similar to that for fentanyl. Here, elderly adults saw the largest increases, which roughly tripled. However, the pattern for cocaine skews older. That's consistent with reports that some of the people dying of cocaine overdoses these days have been using cocaine for years, in some cases dating back to the cocaine crises of the 1980s and 1990s. The difference is that today, the cocaine supply is deeply intertwined with deadly fentanyl. Again, elderly adults saw the largest increases in cocaine overdose deaths, with the rate tripling among those aged 65 to 74 and more than quadrupling among those aged 75 and older. This chart shows death rates by drug type and race and ethnicity. These are important because they illustrate that the drug threat landscape varies across racial and ethnic groups. For fentanyl and prescription opioids, deaths are highest among American Indian and Alaska Native people, Black people, and white people. There are also sizable disparities in the magnitude of increases in fatal drug overdose deaths since the pandemic. For instance, while fentanyl overdose death rates almost doubled for the total population, they more than quadrupled among American Indian and Alaska Native people during that same time period. For methamphetamine, deaths are highest among American Indian, Native Hawaiian and Pacific Islander, and white people. Although Black people experienced the largest increase in death rates from 2019 to 2023, with their rate more than tripling during that time period. And for cocaine, Black people are the only group with a death rate higher than the population average, and they also saw the largest increase, which more than doubled during this time period. For these data by level of urbanization, I'm presenting estimates from 2022. Unfortunately, the CDC has stopped publishing these data as rates, so they aren't available for 2023. However, I've been tracking these patterns for years, and they've remained relatively consistent. So the 2023 data likely don't look too different from these. Fentanyl and cocaine overdose deaths tend to be higher in large and small to medium metros. The Twin Cities in this case would be an example of a large metro, while cities like Rochester and Duluth would fall in the category of small to medium metros. While methamphetamine deaths tend to be higher in non-metro areas, as well as small to medium metro areas. Deaths from prescription opioids are relatively comparable across levels of urbanization throughout the US. The CDC has also started recently publishing data on drug overdose deaths by level of education, but they aren't released as rates like those other data I presented. So what I've done here is turn them into ratios that compare the distribution of drug overdose deaths against the distribution by education for the overall population, wherein a number of 1.0 means that overdose deaths are occurring in the same proportion to the population distribution for education level. I want to mention that these data are limited to people aged 25 and older. Otherwise, young people would skew the results to lower education levels simply because they hadn't completed their educational trajectories yet. What we see here is that for total drug overdose deaths, people with only a high school education or less than a high school education are dying of drug overdose deaths at a very disproportionate ratio, meaning they are overrepresented by far among drug overdose deaths. Conversely, people with an associate's degree, a bachelor's degree, or some kind of advanced degree, such as a master's, a PhD, a medical degree, other kinds of professional degrees, are underrepresented among total drug overdose deaths. With a ratio of 0.9, people with some college but not a degree are slightly underrepresented under drug overdose deaths. Here we see that general pattern holds pretty consistent across drug types. The only real caveat is that the disparities are slightly less stark for prescription opioids. They aren't an equal opportunity killer by any means, but they're more so than fentanyl, for instance. Finally, I want to peek at some more recent data on the overdose crisis. This slide may look familiar, but here we're looking at 2023 data versus 2022, the year before, rather than 2019 before the pandemic began. According to this, it appears that the explosive growth in drug overdose deaths seems to have abated, at least for now. From 2022 to 2023, fentanyl death rates declined a statistically significant, if small, 2%, and prescription opioid deaths declined 16%. Cocaine death rates increased significantly, but at a lower rate of 5%. And methamphetamine overdose death rates did not change significantly. Okay, so this is one last slide. These data, again, are different. These are provisional data from the CDC. they aren't available as rates, only raw counts of deaths. What we see is that the rolling 12-month death toll from total drug overdoses appears to have plateaued in 2022 and 2023. Also, there are indications that drug overdose deaths may have declined in 2024, and perhaps by a relatively substantial number. Now, the 2024 data are incomplete and subject to change, really to be adjusted upward as more data are finalized. But I'm relatively confident we're starting to see some declines in drug overdose deaths in 2024. That said, I want to highlight that this hasn't been the first time that drug overdose deaths in the US have declined since the beginning of the opioid crisis. We saw a brief period of plateauing and declining of drug overdose deaths right before the pandemic, which is when they shot up to their worst rates ever. So that said, we need to be careful not to declare victory or let off the gas in opioid crisis intervention efforts. There's no guarantee that this trajectory of lower drug overdose deaths is going to continue. And even if that count of 81,000 deaths in 2024 were final, that would still be roughly double the level from when the CDC originally declared an opioid epidemic in 2011. So a much bigger problem than when alarms were first sounded. That's hardly a resounding success story, at least yet. So that's it for my presentation, but I'm really looking forward to questions and discussion.
Thanks, Colin. I can kick us off with the questions that I've gotten so far. The first one from the chat is whether there's any data on fentanyl overdose deaths for children under 13.
Yeah, there are data available for fentanyl overdose deaths for children under 13. They are relatively small, especially when you're looking at state level data, which I tend to focus on in my work. That said, there's no guarantee those data are going to remain small. For many years in tracking the opioid crisis, didn't include data for adolescents 13 to 17 in my analyses because they were historically so small, but that changed in a very dramatic way during the pandemic. It's something that we certainly need to keep an eye on because that can change. Often those drug overdose deaths involving younger children, younger than adolescents, are many drug overdoses are accidental, but they are accidental in a different way, with young kids grabbing them off a shelf or out of someone's purse or something like that and not knowing what they're ingesting. It's part of a broader issue with drug poisonings among young children. Certainly, as fentanyl and other substances are more widely available, they're a bigger threat to young children.
Thank you. Another question in the chat is if you have any information about the location of the overdoses or overdose deaths. For example, is there any data on whether the emergencies happened in public facilities, private homes, or some other location?
Yeah, so there is a little bit of location data in the CDC mortality files that I work with. In those files, it's pretty broad and not very useful from a policy perspective, I would say, especially since I'm talking to folks predominantly from Hennepin County, that you are going to have in the data, you have probably much more granular, much more useful data in your death records on where these drug overdose deaths are happening. That's something that I would love to talk with folks in Hennepin County about if you have people interested in discussing that issue. That said, it also can be just simply kind of messy in terms of determining where these deaths were happening or where the overdoses were happening. Sometimes someone may overdose at home. They're transported to the hospital, sometimes via an ambulance, sometimes via a private car. And you may not have great data on where exactly this happened by the time it gets to the medical examiner, who is generally the person filling out the death records that feed these mortality files that I was presenting on.
I'll keep going through our questions. So the next one is, are you able to share out disaggregated data looking at communities that are disproportionately impacted? The Native American slash Black community are more highly impacted in Minnesota. Do you have this in comparison to other areas or states?
Uh, so that's a very good point about the differences across demographic subpopulations. There are real disparities, and those disparities have also changed over time, especially during the pandemic era. Some of those disparities really widened. And as the person asking the question noted, those disparities are particularly large in Minnesota. I worked on an analysis with a colleague of mine in the School of Public Health, Kumi Smith, and we looked at those Minnesota data. And that is a particular issue in Minnesota, especially for our American Indian and Black populations. Uh, I have not personally compared those to other states. That is something that is possible. And if folks from Hennepin County or elsewhere in Minnesota wanted to talk about that, I could help folks think about how to do that, or perhaps help with some of the analysis. That's one of the nice things about these CDC mortality files is the CDC harmonizes the data across the states, so you can do comparisons across states with relatively comparable results. That's sort of the trade-off when you're talking about local data like Minnesota has for its own population and its own death records, and what Hennepin County has in terms of its death records. Those are going to be more granular. They're going to be more detailed. They're also going to be more recent. You don't have that same lag like we're talking about here. 2023 data are the most recent nationally finalized data, but you're going to have more data more locally. But then you can't do those same comparisons to other states or other cities and by population demographic subgroups. So I would encourage, if folks are interested in that, to please reach out, and I'd be glad to talk more about that idea.
Thanks. Another question, what are actual numbers of people who died by fentanyl in Minnesota as opposed to rates? This person is wondering about how many white people specifically.
That is a good question. I work in rates because it allows you to do analyses over time and comparisons. It's something I could provide if someone were to reach out to me. You can just send me an email. I just don't know that off the top of my head. I apologize.
I think this one is a comment, but I'll share it. An attendee shared there are definitely youth who are using fentanyl. Unfortunately, we're seeing it a fair amount in child protection and with concerns about exploitation and trafficking as well.
Yeah, that's certainly the case. And as I alluded to earlier, that's a relatively new phenomenon since the pandemic began. Like I said earlier, for many years, I didn't even bother reporting deaths from drug overdose deaths among adolescents because they were so rare until the beginning of the pandemic. But that has changed in a big way. As I mentioned, a fourfold increase in fentanyl overdose death rates among U.S. adolescents just in that 2019 to 2023 period. I think another thing that is important to talk about is to think back to that one of those earlier slides with the pie charts. There's a lot of overlap between fentanyl and other substances that people are using. From anecdotal reports, I have heard that oftentimes the way that adolescents are becoming exposed to fentanyl and related synthetic opioids is through counterfeit prescription drugs. Those may be counterfeit OxyContin, for instance, that are sold from through illicit trafficking networks by drug cartels. What they do is they take fentanyl or similar synthetic opioids. They take other compounds, sometimes methamphetamine. They have industrial grade pill presses in some cases, and they press these counterfeit pills, and you don't know what's in them. And sometimes it's not even like a youth maybe or an adult maybe using what they think is what they think is a legitimate OxyContin pill, thinking there are opioids in there. That's what they're looking for. But in other cases, they may come across fentanyl in a counterfeit Adderall or Ritalin pill, thinking they're accessing amphetamines, but you just don't know what's in there. It's often a mix of different substances.
A couple more questions. One is whether there's data on families with more than one death due to overdose, location or demographics of those families.
So that is not available in the CDC data that I work with. Uh, I would be interested to have a conversation with folks from Hennepin County if folks wanted to talk about it, about whether that is possible with the county's data. I think that also is an area for potentially other kinds of research, qualitative research, conducting interviews or focus groups with folks in the community to understand from their perspective what is happening and what the dynamics are. Because there are, I'm a numbers person, but I also have, like I mentioned, training in journalism and interviewing, and there are things you just simply can't get at with raw numbers, and you need context and you need those stories sometimes to understand what is going on. And in some cases, collecting those stories and getting that context and background through qualitative data collection can help to improve the quality of quantitative data collection. You can improve the kinds of data you're collecting in death records, for instance.
That makes sense. I have two more questions. The first is whether there are any gaps or barriers you've experienced or anticipate in accessing timely and precise data critical to advancing more effective public health responses.
Yeah, so I can talk about long-standing issues and more recent issues. So some of the long-standing issues are simply the long lag time in getting the finalized data from the CDC. We're more than halfway through 2025 right now, and the most recent finalized national data we have from the CDC are from 2023. That's a problem. We've got these provisional data, but those provisional data are not entirely reliable. We know those always go up. It takes time to go through the reporting process and to harmonize those data. I would love to see greater investments in the US in our data infrastructure for measuring mortality, both for drug overdose deaths and any number of other kinds of causes of death in the US. Another big challenge with these data is how blunt they are for measuring the opioid crisis. On one of those first slides, I talked about those four different drug categories that I presented: cocaine, prescription opioids, fentanyl, and methamphetamine. But with the exception of cocaine, each of those is kind of a conglomerate. Prescription opioids, that includes any number of kinds of prescription opioids, uh, like OxyContin and Vicodin. It also includes raw opium. With fentanyl, it's an even bigger issue because you have a wide range of synthetic opioids, and the synthetic opioids in the illicit drug trade are changing all the time. We know that, but the data that we have, because they're all aggregated into a single synthetic opioids other than methadone category. We just don't know how much the drug trade is changing and how much that is affecting the patterns and trends we're seeing in drug overdose deaths. And it's an even more egregious issue for the methamphetamine category that I talked about. I call that methamphetamine because research from the CDC shows that methamphetamine is the predominant cause of deaths from that category, but that the name of that category is actually psychostimulants with abuse potential. And that includes a range of different substances: methamphetamine, other amphetamines, MDMA or ecstasy. It even includes deaths from caffeine overdoses. So it's just a really rough instrument for measuring the drug overdose crisis, and it really hampers our surveillance and our ability to respond effectively. And it's not only going to be an issue now, this is going to be an issue for years or decades to come if this isn't addressed. The US has a long history of recurring drug crises. Just in the past 40 or 50 years, we've had cocaine crises, we've had methamphetamine crises, we've got an opioid crisis now, and the earlier methamphetamine and cocaine crises are seeing a resurgence. These aren't problems that are going to go away in the future in the United States. It's just not what our history shows. So we need to invest in better data infrastructure to understand what's happening and address these crises as they come about. Uh, Looking into the future as well, I will say that more recently concerning signs I have seen is from the CDC data. The CDC has recently made certain changes to the data it has been publishing on mortality, not just drug overdose deaths, but including drug overdose deaths. Uh, as a researcher, I find myself wanting to know more about the changes they're making, the new data they're releasing, why they're pulling back on other data. I have reached out in recent months to ask them questions about the data they've released and have gotten no response, which is a real change. I've been reaching out to them and asking questions about their data for years, and I have always received timely responses from the CDC about those data until this year. So that's a real concern of mine as well.
I have one comment to read out before our final question. So I have a comment in the chat. Lolita Uloa from Hennepin County is leading the response to the opioid epidemic, says you've worked with their colleagues before, and they will definitely work with you regarding work and data. So it sounds like there's a connection there.
Great. I love to have a conversation.
So our last question is whether you can describe the range of SHADAC assistance and expertise provided to local, state, and federal partners.
Yeah, I'll say that the technical assistance that we provide is really varied. We like to come to policymakers and public officials and civil servants and help them to solve the problems that they have where they are. We recognize that folks have different levels of expertise and their questions may vary based on where they are in the government infrastructure. We work with folks ranging from local levels, like I've worked with Hennepin County before. We work especially a lot with states, state policymakers. In the 11 years I've worked at SHADAC, I've worked with states from coast to coast, from Maine to California, and U.S. territories like Puerto Rico and the Commonwealth of the Northern Mariana Islands, as well as federal agencies like the Centers for Medicare and Medicaid Innovation. Generally, what we focus on is helping states to identify and use data sources. In some cases, that may be data sources that already exist, figuring out how to use them or how to improve those data sources. That's been a lot of the work that I and my colleagues have done in recent years, as with an increasing focus on health equity, helping folks in different states and levels of government improve the quality of race and ethnicity and other data that they are collecting to help make sure that we are addressing health equity. You can't measure for the effectiveness of your innovation strategies if you don't have good data. We also help folks in identifying relevant research evidence to help guide evidence-based policymaking. That's often in terms of research evidence scans or literature reviews. That's something that we find can be helpful as sort of staff extenders at SHADAC, because oftentimes folks in public agencies just don't have the particular expertise on narrow topics, or they may not have access to peer-reviewed journals that can require expensive subscription fees, or they may simply just not have the time to dedicate to that because they're pulled in any number of other directions. We also help folks with evaluation projects, which I consider sort of adjacent to research. It's really kind of applied research in my mind. So when folks are attempting interventions to see if they solve policy problems, best practice is to evaluate what you were doing, seeing if it's being implemented the way you thought it would be, what problems you ran into with implementation, what's working, what's not working, what are the results? Was your intervention returning the kinds of results and at the level that you wanted? So that's another area where we provide technical assistance as well as we conduct evaluations for folks and agencies at states and local levels and federal levels. So there's really a broad range. So if folks have questions, I encourage them to reach out. I and my colleagues are always glad to chat. I suspect that the folks at HUP would also be glad to help make those connections. So that's really what gets us jazzed up at SHADAC, to connect with folks in government and really push for evidence-based policymaking.
Thanks, Colin. So that was our last question. I just want to say thank you, Colin, for sharing your time and research with us. I know there was a lot of interest in this webinar, so yeah, really appreciate your time. And thank you to our guests for joining us as well. For our guests, if you have a minute to fill out the feedback form that I just put in the chat, HUP would love to know more about your experience. The link will also be shared in tomorrow's follow-up email. But again, Colin, thank you so much for your time. And to all of our guests, you'll get a follow-up with the recording and Colin's contact information and everything tomorrow. Thank you so much.